when you transfuse HLA matched platelets, or if you transfuse blood components from first or second degree relatives. It can also occur in certain countries when there is a high degree of HLA homogeneity between the donor and the recipients. This is the case, for example, in Japan, and as a preventive measure, they will irradiate all cellular blood products in that patient population. Next slide. So which blood components can cause TA-GvHD? So as mentioned earlier, the products at risk are cellular products, mainly red cells, platelets, and granulocyte concentrates. Some products do not cause serious problems because although they may contain some viable T lymphocytes, they are in such small amount that that there is no case of TA-GvHD reported with those products. Mainly frozen plasma, cryoprecipitate, cryopreserved red blood cells, who are usually cryopreserved for a donor who have rare blood, and also the pathogen-reduced platelets, and Oksana will discuss this in further detail in a few minutes. So clinically, TA-GvHD usually occurs 2 days to 6 weeks after the transfusion, and it's really a clinical syndrome. In order of frequency, the most frequent symptoms will be fever, a rash that is usually erythematous and maculopapular, and usually migrate from centrally to the limbs. You can also have pancytopenia caused by a meroaplasia, diarrhea, and liver enzyme elevation, and you can also have an hepatomegaly. This adverse reaction is almost always fatal, with a mortality rate between 90 to 100%. The way to make a definitive diagnosis is by having a histology of either the skin or the liver demonstrating lymphocyte population of both host and donor. If you don't have the histology, then as according to the CDC, this will be classified as a probable TA-GvHD. So how do we prevent this adverse reaction? As you probably all know, we can prevent this by irradiating cellular blood components. It can either be done using gamma rays, usually it's cesium or cobalt source, or X-ray. The minimum dose to cause DNA breakage and prevent T lymphocyte proliferation is 15 grays. So usually we give a higher dose to make sure that in the center of the products, there is actually 15 grays. However, as you're probably aware of, there are many challenges associated with irradiation. Irradiation does cause red blood cell membrane damage and is associated with a shortened lifespan and potassium leakage. There are some logistical and inventory challenges, especially for remote area. It's costly, and of course, you have to be very cautious and keep in mind all the radiological safety and security measures that must be applied. Next. In recent years, there's been some papers suggesting that although pre-storage glyco reduction does not prevent TA-GvHD, it's a way to mitigate the risk of graft-versus-host disease, and our recommendation address this. You have to take into account the length of time since donation to say that it can be a mitigating measure. So for those who remember the 2018 recommendation, at that time we had a recommendation saying that that instead of irradiated product, you could use pre-storage leukoreduced red blood cells that have been stored for at least 14 days. However, in recent years, there's been a new paper that proposed that 21 days might be safer. So we modify our recommendation to say that Ideally, it should be 21 days, but at least 14 days if you don't have access to irradiated product, either in the case of an emergency transfusion, or if you're uncertain of the risk because of the immunosuppressive potency of new drugs, which are always never in the product monograph. Next slide. So during our work, we did a query of 3 hemovigilance systems in Canada to ascertain the incidence of transfusion-associated graft versus host disease. So we queried the Health Canada Vigilance, the PAC-TTIS database, as well as the Quebec hemovigilance systems. In short, there were no case of TA-GVHD reported in those 3 databases. If we're a little bit more precise, in the Canada Vigilance database, there was 1 report of serious adverse reaction from 2019, which included GVHD in its coding. However, when we reviewed a little bit further this case, it was actually a serious allergic transfusion reaction in the context of a patient with a GVHD secondary to haploidentical stem cell transplant. So transfusion-associated graft versus host disease was not a consideration. So I will now turn to Oksana, who will walk you through the rationale for publishing an update of the 2018 recommendation.
Thanks, Nancy. All right, so the initial document detailing indications for irradiation has a history beyond the version that was just published last year. So in 2014, the Canadian Blood Services Provincial Territorial Blood Liaison Committee requested that the National Advisory Committee on Blood and Blood Products, or NAC, develop recommendations for the use of irradiated blood component transfusion in patient care. This was because it was noticed there was significant variation in irradiated blood transfusion practice nationwide. And this is a costly modification to red blood cells that isn't benign. As Nancy mentioned, there is impact to the red cell quality. And now there's some emerging evidence that there may be some impact to platelet quality, although that aspect is still under investigation. But the cost was certainly a concern. So in follow-up, the NAC assembled an irradiation working group who invited representatives of Quebec's CCNMT to collaborate as partners in this recommendation development process to truly publish a national document. So just looking at some figures from operational fiscal years, in 2004-2005, CBS had reported that there was about 4.5% of their inventory that had been issued as irradiated to hospitals. In 2015-16, before the publication of the initial version of the document, but as work was underway, it was noted that this rate had increased to 6.7%. And in parallel, Héma-Québec had also seen about 6% of blood issued was irradiated. Now, looking province to province, there's a surprising variation in terms of the percentage of irradiated red cell units issued by CBS, and this ranges from 1 to 20% depending on the province. And you might wonder, well, why is there so much variability between the provinces themselves? And this is predominantly because irradiation that occurs at Canadian Blood Services may lead to red cells that need to be transported to a variety of different hospitals. As a result, there are some more geographically, I'll say not so much remote, but distant sites from Canadian Blood Services that do have their own irradiator in the hospital facility. And so if hospitals don't actually have an irradiator, they need to order the blood from CBS. But if they do have an irradiator, they can complete that irradiation on site. So sites that have an irradiator outside of CBS, the data in terms of number of units issued or transfused isn't actually captured in these numbers. So that's why some provinces seem to have a disproportionately low rate of irradiated blood issues from Canadian Blood Services. It was also found that, again, there are differences in regional transfusion practice patterns. Back before the guidelines were, or the recommendations were published, there were some provinces that were irradiating red cells for all patients with an oncologic diagnosis, for example, whereas others were more stringent and followed existing British Committee for Standards in Hematology recommendations, which were available at the time. So we needed to bring things into alignment. To compare that to more current data that was gathered during this most recent review, 5.9% of blood inventory issued from CBS was irradiated on average, and 5.6% from Hema-Quebec. So that has fallen, which shows that people are being a little bit more cognizant of who is receiving irradiated blood and why. But certainly there is more work to be done in ensuring that appropriateness is optimal, and patients who don't have indications for irradiated blood transfusion aren't receiving an inferior product. So as Nancy has reviewed, there is evidence of negative impact on red cells because of essentially damage to the phospholipid membrane of the red cells themselves, leading to a shortened lifespan, as well as potassium leakage, which is a concern in any cells that have to stay on the shelf, essentially post-irradiation storage lesion that leads to this potassium leakage. So as such, there is this shortened storage period, and CBS had recently, in the last several years, shortened their maximal storage period post-irradiation to 14 days, and this now aligns with what is in the CSA standards. So everybody is practicing in accordance to what is within the CSA 2020 standards. As mentioned, we currently don't modify the shelf life of our platelet units that are irradiated. However, there is some emerging evidence that there may be some increase in vesiculation of the platelets, shortening their in vivo survival, but that has not yet been demonstrated as a clinically significant impact in patients. So the purpose of this recommendations document is really to describe the TA-GVHD complication as a transfusion adverse reaction and how irradiation prevents this complication, and then ultimately to provide evidence-based clinical practice recommendations to guide appropriate blood component utilization in practice. So the initial document was written between 2014 and 2017, with the final document published in 2017. And in accordance with the NAC 3-year document review schedule, this document was identified to require routine review in 2021. So just based on workload and priorities, this document was slated for review with a subcommittee, sort of renamed from working group, but a subcommittee reconvened in January 2022. And I'm very grateful to Nancy for agreeing to co-chair that work. So we had an excellent team of individuals, which included CBS scientists, clinical hematologists, as well as hematopathologists, both from the NAC and CCNMT, that completed this work. So foundational publications were used as resources for these documents. We did not have a fulsome sort of grade review of the literature. We did not have sort of the same process that some of these guidelines documents published in the literature had undergone. So for the 2017 publication, we really heavily relied on the guidelines for prevention of TA-GVHD from Australia and New Zealand, published in 2011, as well as from the British team in 2010. For the 2022 guideline, we once again, or sorry, I should clarify, our recommendations document, because again, it's not a proper guideline, but our recommendations document focused on published guidelines from the Netherlands in 2021, and once again from the British in 2020. It's important to note that although we did consult the Australian New Zealand literature that was published and inquired as to whether there was an updated guideline, indeed, no, there had not been as of 2022. So that's why we shifted to the Dutch and the British guidelines as our foundational sources. In addition to this, just to supplement and make sure that we didn't miss any case reports or any significant literature related to TA-GVHD, there was a review completed of publications from January 1st, 2017 to January 31st, 2022. As well, data on the stored red blood cell quality was evaluated, and we're grateful to Canadian Blood Services for some of the research that they had done in this regard. I'll also acknowledge that Hema-Quebec librarians helped with the literature review that was completed as a part of this project. So next, subcommittee members provided an editorial review and update of the 2017 recommendations document, and that was completed between 2022 January and 2023 July. We also had introduced to the transfusion community proposed significant revisions at CSTM 2023 with an oral abstract presentation. That ultimately led to some minor revisions and an updated draft document that was circulated for stakeholder feedback between August and September of 2023. So in the table here is a list of community stakeholders that were consulted and who provided a response to help provide feedback on the comprehensive draft that was written. So once again, there were some comments, very valuable ones made and minor revisions made. And then this version of the document was circulated one final time to the irradiation subcommittee and then discussed and ultimately approved by the NAC and CCNMT in September at their respective committee meetings. The final stage to a document like this becoming approved and sort of released for use in Canada is that a briefing note was submitted to the Canadian Blood Services Provincial Territorial Blood Liaison Committee, to which the NAC is advisory. So they are our overarching body. And they reviewed and ultimately approved the final document, which is published online as of October 2023 on the NAC website. And then CCNMT has a version in French as well that is available on their website. So the last part of this presentation, we'll be summarizing Sentinel updates to the recommendations document and rationale for these revisions. I'll begin with more adult-focused topics, and then Nancy will close our presentation with updates focusing on pediatric and neonatal patients. So one of the newer blood components that's available through Canadian Blood Services are sorrel-treated platelets. This sorrelin treatment is a type of pathogen inactivation technology and combines not just sorrelin, but use of UVA illumination that ultimately cross-links the DNA to destroy it within not just pathogens, but it also happens that it affects white blood cells in the same way. So the pathogen inactivated technology and its initial intent to deactivate viruses and bacteria also has this benefit of inactivating white cells and essentially functions as a parallel to irradiation in mitigating transfusion-associated graft versus host disease for patients at risk. So this sorrelin treatment, UVA light, process by the intercept system is currently only applied to platelets. This same system cannot be applied to pathogen inactivation of red cells due to compromise of the red cells otherwise. So the pathogen inactivated technology platelets are currently available through CBS. To my understanding, Hema-Quebec has not embarked on releasing pathogen inactivated blood components yet at this time. So for sites who receive pathogen inactivated platelets, these are considered a radiation equivalent and may be issued to patients who have requirements for irradiated blood without additional modification. So pathogen inactivated components should actually not be irradiated because they're already considered TA-GVHD mitigated or safe for patients. We had also recognized that there are significant gaps in the Canadian hemovigilance data in terms of even recognizing and potentially reporting not just confirmed cases of TA-GVHD, but presumed cases. So our TTISS, or Transfusion Transmitted Injury Surveillance System guidebook, is fairly old in terms of timelines. It's from 2007. And that document currently outlines diagnostic criteria for TA-GVHD, but there really hasn't been discussion about encouraging possible or probable cases. Often clinicians want to really be sure because this is a big deal. The other thing that we don't know and have not gathered data about is near misses or errors in terms of who was supposed to receive irradiated blood but didn't, where there was an error and individuals had received standard components. We do have examples from the United Kingdom, and they have the Cadillac version of a hemovigilance system through the UK SHOT database that does describe near misses in addition to cases of TA-GVHD that are possible, probable, or confirmed. Within the last 10 years of the SHOT database, there haven't been any cases of TA-GVHD, but there sure have been near misses, and a significant number of them. Most of this is related to human error, but it would really be nice to be able to track our own hemovigilance data in a more fulsome way so that we can learn from these situations as well. So we have added new recommendations related to hemovigilance monitoring, suggesting that hemovigilance data should be maintained by the Transfusion Medicine Service on patients with indication for transfusion, but who were actually transfused with cellular components that were not irradiated or considered irradiation equivalent. And where this error occurred, documentation of the circumstances should be recorded within jurisdictional safety systems. We wanted to make sure the caveat of the circumstances being recorded was included, because there may be scenarios where, let's say, someone has an indication for irradiation, but then all of a sudden there's a massive hemorrhage protocol activation, and there's actually not time to irradiate the units. And it's a conscious decision just to pull the older units from storage to transfuse to that patient. So certainly that in that case, they didn't receive irradiated blood, but they received sort of what we consider to be next best and safest in that critical circumstance. Further to that, there's a recommendation where a patient with indications for irradiated cellular blood transfusion is identified to have received non-irradiated transfusion unintentionally or out of necessity. There is a discussion then that takes place in terms of the transfusion physician and most responsible healthcare provider to do a risk assessment. And if the risk assessment is determined significant, then the physician who placed the order for the implicated transfusion is responsible for communicating the incident to the patient. So that communication typically would be in a circumstance where truly there was an error. And let's say a patient with a high risk for TA-GVHD, like a patient with aplastic anemia who's actively receiving ATG, for example, gets a non-irradiated unit, and that was a mistake. So then a review would have to occur in that type of circumstance, and documentation of that error within the local hemovigilance system. And that type of error would actually be eligible for reporting to tests. We actually have a voluntary reporting transfusion error surveillance system in Canada. It's minimally used and unfortunately widely underfunded. So we certainly have work to do as a national hemovigilance system to essentially strive to become like the UK SHOT system. And finally, there is a recommendation for all cases, not just of confirmed, but also suspected TA-GVHD to be reported to the blood operator as soon as possible, including prior to completion of the investigation. So there is some discussion within the recommendations document about what signs or symptoms may evolve. And there's also a link to the National Health and Safety Network Biovigilance module from the United States, which is the most descriptive in terms of what would be considered a possible or a probable case of transfusion-associated graft versus host disease, even if you don't have the tissue diagnosis of two genetically distinct white cell populations within that tissue. Moving on to bone marrow transplantation, we did elect to align fairly closely with the British 2020 guidelines, but interestingly, where they had some should terminology, we have agreed that there should be shall terminology. So for instance, adult and pediatric recipients of allogeneic transplants shall receive irradiated components from the time of initiation of conditioning chemo or radiation therapy. Whereas the British, interestingly, have a should comment there. Further to that, if patients continue to have graft versus host disease, they should continue to receive irradiated blood throughout the time of receiving prophylaxis. Interestingly, there was conversation this time about when to potentially lift indications for irradiation. So up until recently, there had been the assumption that if someone's had an allogeneic bone marrow transplant, they should just receive irradiated blood forever, right? Most labs had followed that that recommendation. However, there has been some evolving data to suggest that perhaps these patients shouldn't be exposed to inferior products if they're otherwise doing well post-transplant. So the British had outlined some very specific criteria about when at least a year post-transplant, if specific criteria are met, then there could be considerations for lifting the need for a radiated blood transfusion. So this would be, for example, if more than 6 months have elapsed since the transplant date itself, if the lymphocyte count was more than 1, if there was no evidence of TA-GVHD, and if all immune suppression was discontinued. So I should clarify that it's more than 6 months from the transplant if all these criteria are met, and the 1 year applies to the indication for irradiation being held in that patient's blood bank file to be reviewed at least yearly if it hadn't been removed, let's say at that 6-month mark. Perhaps at a year or at 2 years, if all of these criteria are met, then there could be consideration for removal. It's important to note that this would not be the responsibility of the blood bank to drive the question and ask. Really, it should be the discretion of the transplant team to request lifting that indication for irradiation. Certainly a conversation can happen back and forth, but it's not something where the onus would be on the blood bank to automatically lift the indication without that directive from the transplant team. We also added some recommendations related to donor lymphocyte infusion. Our previous document was silent on that, so there was just a recommendation included to discuss DLI. So the irradiated components should be continued in this context post-transplant, and the duration should be contingent upon clinical factors related to engraftment post-transplant and the presence of acute or chronic acute or chronic graft versus host disease from the transplant, not from any transfusions, and ongoing immune suppressive therapy. The previous document also did not address CAR-T therapy, as that was a new and emerging therapy for certain types of malignancies at the time. So the British Committee for Standards in Hematology did also include some recommendations related to CAR-T therapy, which we modified slightly just based on what made sense. The British guidelines essentially made recommendations for CAR-T patients to be essentially considered to be analogous to autologous bone marrow transplantation patients. In conversation with our colleagues, there was essentially universal agreement that all CAR-T patients receive some kind of a purine analog-based conditioning without exception. And so if that's the case, just based on some of the pharmacologic recommendations, which I'll be discussing shortly, that the recommendation should really be that CAR-T patients receive irradiated blood until at least 6 months following CAR-T cell infusion. So that was the one difference compared to the Brits that we made. The next few slides are a little bit contentious because there are some discrepancies in the two guidelines, the British and the Dutch, as they relate to Hodgkin lymphoma and then some pharmacotherapies, which we'll discuss shortly. So there was an interesting paper published in the British Journal of Hematology in 2021 that essentially was a comparison document, essentially a crosstalk or crosswalk rather, between the British and the Dutch guidelines, and essentially identified that the same resources or the same references within the literature were actually used to ultimately come to different conclusions, which was quite fascinating. So one of those examples relates to Hodgkin lymphoma. So there was a discussion within this paper comparing the two guidelines that suggests that TA-GVHD in Hodgkin lymphoma is indeed higher than non-Hodgkin lymphoma, but that there's a paucity of high-quality published evidence, which ultimately leads to a lack of certainty regarding recommendations. So the British are pretty vocal in saying the absence of reported cases in the literature doesn't necessarily mean that there's an absence of TA-GVHD cases. It just means that they're not reported. So whereas the Dutch have basically said for Hodgkin lymphoma, there's no requirement for irradiated blood, and the British have said, well, really at any stage of the disease, the patients should receive irradiated components indefinitely. So quite polar opposite perspectives there. So from an expert opinion perspective, our irradiation subcommittee really looked at the evidence, looked at those guidelines and said, okay, what's practical? And what would the evidence support, even though the evidence is very limited? So ultimately, with much discussion and deliberation, we have made the recommendation that all adults and children with Hodgkin lymphoma should receive irradiated red cells and platelets from the time of diagnosis to a minimum of 6 months after remission is achieved. Now, that's a recommendation. Again, this is not sort of based on high quality evidence, because there is no high quality evidence. There is a paucity of evidence. Ultimately, then the decision to discontinue transfusion of irradiated blood components is at the discretion of the treating physician. So there still is that permission that if somebody in the treating team have determined that this person had a low-grade Hodgkin lymphoma, has responded well to therapy, or 6 months post-remission, it's appropriate to lift that indication. Whereas if it's someone who had a high stage or grade of Hodgkin lymphoma, let's say they're in remission, but then 2 years later develop some other chronic transfusion disorder such as myelodysplastic syndrome, well, one could make the decision that perhaps that's a patient that would require irradiated blood transfusion due to their complicated course in this post-cancer situation with an underlying Hodgkin lymphoma diagnosis at the outset. So there really needs to be that clinical consideration of the individual patient case for situations like this, where there really is minimal data around to provide a firm response or a firm decision. Just a reminder that non-Hodgkin lymphoma diagnosis on its own is not an indication for irradiated blood component transfusion. And there's the whole profile of medications that should also be considered when making a decision with regards to patients who have non-Hodgkin lymphoma and irradiated transfusion. Similarly, there are some differences within the recommendations as they relate to purine analogs. The British suggest that anybody who gets purine analogs should get irradiated blood indefinitely, whereas in the Dutch guidelines, they recommend for a minimum of 6 months after cessation of therapy. Once again, there's a paucity of high quality evidence that ultimately, despite review of the same evidence, lead to 2 different conclusions. One thing that is reassuring is that there are no cases of TA-GVHD per the UK shot since introduction of pre-storage leukoreduction. And they do discuss situations where there have been these misses of patients not receiving irradiated blood when they should have based on medications given, and they've not been subject to TA-GVHD. So our subcommittee recognized the limitations in the data and did provide some statements in terms of what to do with patients who receive purine analogs and purine-like analogs. With great discussion, stakeholder review, consideration, we did suggest that indications for irradiation can be lifted at a minimum of 6 months after treatment cessation. But again, that would be in discussion with the treating physicians and contingent on the clinical status of the patient. So purine analogs include things like fludarabine, cladribine, pentostatin, and elarabine. So for a minimum of 6 months to receive irradiated blood until a minimum of 6 months after cessation of therapy. And then with purine antagonists or related purine-like agents like bendamustine or clofarabine, we really couldn't sort of make a firm recommendation about whether these truly are associated with TA-GVHD risk. Certainly the molecular structure of these medications makes them suspicious because they look so much like purine analogs on a chemical, from a molecular structural perspective. So a similar recommendation was made where patients should receive irradiated blood components for a minimum of 6 months after cessation of therapy. With regards to alemtuzumab and ATG, there again was a little bit of difference between the 2 guidelines. Recommendations regarding the use of irradiated components in the context of potent targeted T-cell antibody therapies do ultimately differ depending on the underlying patient condition. So where the British couldn't really define a timeline, the Dutch suggested that with CD52, anti-CD52 agents like alemtuzumab, there could be a consideration for removing irradiation from 6 months after completing treatment. So we followed along with that. So patients who've received alemtuzumab in the context of aplastic anemia or hematologic malignancies shall receive irradiated components for at least that 6 months after cessation of therapy. But we've been a bit wishy-washy with the ATG. So we've said that patients who've received ATG for aplastic anemia or hematologic malignancies should receive irradiated blood components, but because there really is a paucity of evidence and because of how suppressive ATG is to T cells, we could not make a recommendation with regards to the duration for irradiated blood use in patients with aplastic anemia. So to translate that, what functionally I think that's going to mean in most labs is patients with aplastic anemia who got ATG will likely then get it for life, but ultimately that will be up to local policy to determine based on the fact that the NAC couldn't make a firm recommendation. There had also been conversations about the use of ATG and anti-CD52 antibodies in the context of non-hematologic indications. So ATG is not uncommonly used as a part of conditioning for solid organ transplantation, and then anti-CD52 in the context of multiple sclerosis or vasculitis. And ultimately, the consensus based on available literature at this point of time is that those are not indications for use of irradiated blood. And then finally, we added a recommendation about new and emerging pharmacologic therapies, encouraging all care providers that if there are new medications released onto the market, that the product monograph should be consulted to guide the use of irradiated blood components. So at this point, I'll turn it over to Nancy with her focus on neonatal and pediatric patients.
Oh, thanks, Oksana. So I will cover two topics. The first one will be congenital immunodeficiencies. So as you may be aware, there are many provinces and territories who have implemented newborn screening for kids over the last decade. So our former recommendation had nothing about this. So we basically had a new recommendation where we strongly recommend that in provinces or centers where there is neonatal screening for SCID or other severe T lymphocyte immune deficiency, that there should be a communication mechanism established to ensure screening tests and confirmatory test results are communicated to the transfusion medicine service to ensure that these patients are appropriately targeted and receive irradiated blood components. So as you can see in the list, in the last bullet, almost every provinces now do offer newborn screening for SCID. Slide. Okay, so you might remember that the 2017 recommendation had one statement about congenital immunodeficiency. And basically, at this time, the statement said that all severe T lymphocyte immune deficiency syndrome should be considered as an indication for irradiation. And once a diagnosis of immunodeficiency was suspected, irradiated components should be given until a final diagnosis was made. And if we were unsure, then we should consult with a clinical immunologist. And basically, those were based upon the 2010 British guideline. In their new version, the British guidelines now have 5 recommendations. And we basically align with those new guidelines. The first guidelines was basically split into 2 different recommendations, so it's mostly editorial, but there were 2 recommendations that I wanted to address today. The first one has to do with patients for infants who have cardiac defects. So it's very difficult sometimes to know if we need to irradiate or not because the final diagnosis is not made. So in the new recommendation, it reads that neonates and infants with suspected immunodeficiency syndrome should undergo investigation for T cell immune deficiency prior to cardiac surgery. However, if this has not been done or the results are not available, the product should be irradiated until the investigation has been completed. However, for adults or children aged greater than 2 years who do not have a significant history of infection or are referred for elective cardiac surgery for defects associated with Dijon syndrome, such as aortic arc anomalies and pulmonary artery stenosis, or in whom Dijon's anomaly is suspected, they do not need to receive irradiated cellular blood components unless they have a personal history that is consistent with severe T lymphocyte immunodeficiency, mainly an history of severe or recurrent infection, because the risk of TGVG is considered to be extremely low. And next slide. So regarding neonatal transfusion, there are major changes in this edition. First, you might remember that in the previous edition, we had circulated a survey to Canadian transfusion medicine lab about their neonatal practice. So this was a little bit outdated, and we basically removed it from our recommendation. We added a specific statement saying that if maternal blood is to be used for a neonate, it must be irradiated. It felt already under the recommendation saying that if you transfuse blood from a first degree or second degree relative, it should be irradiated, but we really wanted to make this clear. In fact, when you look at the shot data, the only case in the last 20 years that was reported for THVHD in a neonate was a case where maternal blood was transfused and was not irradiated. So the major change we did for this edition was the removal of the need for irradiated blood for top-up transfusion to low birth weight premature babies. We are quite sensitive to the fact that this may cause discomfort because it's really a shift in practice. It does align with both the Dutch and the British guidelines. Of course, there's no randomized control trial upon which we can base our decision. But mainly we base this decision on the fact that the United Kingdom has not performed red blood cell irradiation for small volume transfusion to very low birth weight since 1996. So basically when they introduced pre-storage leukoreduction, and they had no case of THGVHD. Similar data from the Dutch, and actually in most European countries, irradiation is not performed for neonatal transfusion. If we look back, actually, the historical case of neonatal THGVHD occurred in the pre-leukoreduction era. And as you might all be aware of, both CBS and Héma-Québec perform universal pre-storage leukoreduction since 1998. And when we look at the Canadian database, although they're not as robust as SHOT, as I said earlier, there was no case of THGVHD. So the recommendation is that premature babies defined as less than 1,500 grams birth weight or less than 30 weeks gestation do not routinely require irradiated red cells or platelets, except if you suspect congenital immunodeficiency or following an intrauterine transfusion. So it's not a shall, because we know that it would create discomfort, but if centers, after discussion with their the neonatal team, feel that, I would say, feel comfortable with this, it's totally correct not to irradiate a blood product for this patient population. So in conclusion, I think this talk probably addressed the fact that appropriate use of irradiated blood for TA-GvHD prevention is essential in providing optimal patient care. The updated NAC-CCNMT recommendation published last October reflect current literature and practice, and we invite laboratories to review their policies and procedure to ensure alignment of practice with the updated Canadian NAC-CCNMT irradiation recommendation. And finally, we would like to acknowledge the amazing work of both Mrs. Arlene Kalin and Mrs. Kendra Stewart for their work as NAC coordinator. All the irradiation subcommittee members, actually, I think we have 2 of them with us today, and all stakeholders who reviewed the document in advance of publication. And of course, Health Canada, Canada Vigilance, Quebec Immovigilance System, PIAC, and TTISS staff for providing TA-GvHD immovigilance data. We want to thank you for your attention, and Oksana and I will be glad to answer any question you might have.
Thank you both so much. That was absolutely wonderful. And we're grateful to have both of your expertise in this matter. I have a practical question before anybody else asks the question, but if you have questions, please raise your hand and we'll get to you guys. So within the limitations of every hospital's sort of ordering systems, I'm wondering, like, we have some issues with certain parts of the hospital, like let's say leukemia BMT, where they might order irradiated products one time and then it's not irradiated ordered and then it ordered irradiated. So I just want to know what your approaches are, or practical approaches, to be able to ensure that we're not inappropriately irradiating or missing irradiation, but also with the limitations of screening every single time certain sites or certain parts of the hospital are ordering irradiated or not.
Did you want to take this one first, Nancy, or do you want me to?
Well, I think each institution probably has its own way of doing things. I can share what I was doing at St. Justine Hospital. For certain, so in our order sets, we included all the indication for irradiation as a reminder for prescribers. So that was a first step. In our blood bank SOPs, we had the same indication, and actually our lab technologists were quite good to screen patients when they see an indication. If they were not sure, for example, during weekends or at nights, they would give irradiated product. And the next day, the medical blood bank director would review the indication. And if there is an indication, it's actually registered into our LIS, and it overrides, I would say, what is written on the physician request. So, for example, if a patient, and for some patient population, it's already in the order set. For example, for patient would undergo BMT, it's written in the order that they should receive irradiated blood product, and the BMT team and the cellular therapy lab would advise us that there is that the patient is undergoing a BMT, and then we add it to our LIS. So that's how it's not perfect, but it was quite good, I would say.
Ours is sort of similar. So I'm based in Saskatoon. And so what we have done is on the blood product request form, like that the clinicians need to fill out, including the nurses, after the doctor writes the order. On the reverse side, we have a list of the indications for irradiation, so people can have an easy reference of where to check. We also have a system of implementing in the LIS a comment that if someone has an indication for irradiation, let's say aplastic anemia with ATG, that's actually typed in, so that if at a future instance a unit of blood is ordered and there isn't a request for irradiation on the rec, our techs know to issue irradiated blood as a safety precaution. unless there's removal of that indication. So if we have had a couple of situations where we've removed the indication, and then there's a follow-up LIS comment saying indication removed and such a date and what physician, and both the transfusion physician and the BMT doctor or the hematologist name go in there, so that it's clear as to when and why that happened.
Thanks so much. I see Dr. Clark has her hand up.
Hi, thanks, Krista. I don't have a camera, so I can't put my camera on. Thanks very much, Oksana and Nancy. That was a really nice overview, and I appreciate what a huge amount of work it was to bring these together. So it's really nice to have this great document. I have sort of two sides to the same question. The first is you commented a couple of times, Oksana, that for those indications where it might be possible to lift the requirement for irradiation, that's in the hands of the treating physicians. And I appreciate that that's appropriate, but my practical experience is that in general, the treating physicians think that irradiated is always safer and that it's unlikely that they would lift an indication. It tends not to be much of a clinical attention paid to the quality of the red cell when it's irradiated. So I feel like while it may be their decision, that in some cases it may be useful for the blood bank to prompt that request. I'll give you an example. Somebody had a bone marrow transplant remotely. They're well and off all medications. They come back years later because they've fractured their hip and they need a transfusion in emerge. So we've still got in our LIS an indication of allo-BMT that they need irradiated blood. So nobody clinically is going to take that off, and unless the blood bank initiates that. So I think sometimes the blood bank will have to initiate those things unless you're willing to just go ahead and give the irradiated blood. So that's one side. And then on the other side, I'm always interested in the issues around Hodgkin's disease and purine analogs, because I think the blood banks almost never have any information about whether a patient has particularly a remote history of Hodgkin's or how they were treated or what stage it was. No blood bank I've ever been associated with has ever known that. And I think lots of times it's just not ordered in that context. So I think there's lots of people that have had treatment for Hodgkin's that have never gotten irradiated blood and that have never gotten transfusion-associated graft versus host disease. And I think the same is true for purine analogs. I think there's lots of people on those drugs that the blood bank never knows about and that we never give irradiated blood to and who never get transfusion-associated graft versus host disease. So I don't know how we get out of this conundrum, but I suspect there's a lot of clinical experience out there that would tell us what Schott has kind of said, that they know there's been errors or misses and still no TA-GVHD. But I wonder, just wearing your academic and policy hats, is there some way to collate the data on all these patients who have never gotten irradiated and never gotten TA-GVHD, and whether we could use that sort of bank of, I suppose, misses to fuel some policy change? Thanks.
Thanks, Gwen. So I will do my best to address the very many points within what you've just said, both statements and questions. So I guess I should maybe clarify my statement in that it's absolutely appropriate for blood bank to prompt and ask the question as to whether it's appropriate to remove an indication for irradiation in the situation like you've provided. Prompting, yes, but in terms of, there had been some question about, well, should blood banks set an automatic flag 6 months post-transplant and just automatically remove the indication for irradiation if they on their side see that certain requirements are met? Or if there is a communication from pharmacy, set an automatic time, some kind of a notification to remove indications for irradiation. That's what we want to avoid in terms of blood bank, in terms of that automatic removal of the indication, but certainly flags to then, let's say, have some kind of a notification to perhaps approach the clinician saying, hey, this certain timeline is passed. Might it be appropriate? Can you review the case and let us know? So I think that's where the difference is just to make sure the blood bank's not doing something that's automatic for the patient care without the treating physician guiding the decision in the first place. I think that the data that you referred to, or the sort of interesting situation that we're in terms of many patients with Hodgkin lymphoma are having received medications like purine analogs, having received non-irradiated units because the blood bank hasn't known, is a real one. And to be honest with you, my interpretation is it's that data that's actually helped drive the lifting of the indication for irradiation for these patients in this current iteration of our recommendations. How can we track or assess or review patients who maybe haven't received irradiated blood components and what their clinical status is now. I think the only way to do that is manually. And that's a huge undertaking unless people within their systems, within their lab information system, start tracking either errors or near misses or what have you, to be able to somehow feasibly pull this data electronically. I think that our hemovigilance system certainly isn't there in Canada, and it's really, really difficult to be able to get that kind of data right now. But perhaps with better tracking, we'll have an opportunity to collate such data in the future. The final comment I'll make is that communication is key. Some blood banks have actually set up notifications from their cancer center pharmacies to receive lists once a month of patients who receive purine analogs when they start, or things like ATG, so that there can be blood bank comments put in, similarly to how we do enter comments for our stem cell transplant patients for those who have products processed by the cell therapy labs and things like this. So different sites have set up different communication strategies to identify these pharmacotherapeutics. But otherwise, in terms of diagnoses, we are really relying on good communication from our clinical teams, and that can certainly be difficult and lead to gaps. Hopefully that addressed the majority of your comments. Hopefully I didn't miss something. Nancy, I don't know if you have anything to add there.
Well, actually, the only thing I might add is that this is the reason why we added a recommendation about reporting near misses. So if we can collect enough data, maybe at some points will we be more reassured to lift some of this indication or to shorten the interval for which patients should receive irradiated blood components.
Awesome, thank you. Now, Dr. Morrison, I saw you came on camera, so I assume that there's a question coming. Maybe the last one, because we're already over time.
No, I just wanted to thank Oksana and Nancy, for all the work that they've done in the revising these recommendations. I know how much work it's had been for you, and we really appreciate it. I also think that you've done a beautiful job in your presentation of giving people an understanding of the complexity of these issues, and they're not black and white issues, or they're not easy, and significant decisions have to be made. So do appreciate all the work you've done. And I have lots of questions, but no time.
Thank you, Doug.
Yeah, and thank you on behalf of our BC Transfusion Medicine community. Thank you both for being here. You're always welcome to come to our rounds, and we will include you on the registered link, hopefully going forward, so that this can be across Canada attended rounds if people are interested. So thanks again, and yeah, we'll see you guys next month. Bye.